This conference will now be recorded.
Guys, there's a bit delay because of this technical snag. Yeah, 23 and counting. Yes, can we start? Somebody give a call so that we'll start the session. Hello, am I audible?
Yes, sir.
Hello,
Yes, sir, audible. Audible, sir.
hello. Yeah, Sneh.
Sir,
Thank you, Manasa. Thank you. Shall we start then? Okay, we'll start. Okay. Because it's considerable a bigger topic. Yeah, it is of theory, more of theory than of practical for you guys. Yeah. Yeah. See, in neonatal sepsis. Okay, this is a newborn topic. Okay. What is this ambient sound? Okay. Yeah, this is a relatively your theoretical question because this is a newborn topic which is not expected of you to know much about in practicals actually, but in theory, yes, it is important. Okay. As the name suggests, it is the infection sepsis of the newborn. Okay. The few definitions to go by, like the definition is neonatal septicemia is defined as generalized systemic features of infection. It is generalized systemic features of infection associated with pure growth of bacteria from one or more sites in a newborn. It is because of the bacteria, and it is affecting one or more sites, and it has to be generalized. Okay, that is septicemia. See, something like emia or whatever the suffix is, that means that it is hypoxemia, anemia. So it is a more generalized term. Okay, septicemia means it is all over the body. Okay, yeah, yeah, and it is one of the most important cause of mortality and morbidity in newborn, like in developed nations or developing. In developing and underdeveloped, this is one of the most important cause for mortality and morbidity of the newborn, and it accounts for your infant mortality rates. Okay, so this is the concern why we have to be worried about neonatal sepsis, and we have to deal appropriately. Okay, this is mostly seen in preterms who are not totally immunologically protected towards the impending infections. Okay, and low birth weight babies, the same thing. Okay, yeah. Coming to the stats, incidence is 30 per 1,000 live births, and mortality is around 4%. Okay, in those who get septicemia, mortality is around 4%. Okay, if diagnosed early and treated aggressively with antibiotics and good support care, yeah, most of them can be saved, and they can be discharged. Okay, that is the main concept why our government in India has started SNCUs. SNCUs are your newborn care centers, where you can actually, they'll identify it early and they can shift it to the NICU appropriately so that to decrease the infant mortality rate. Okay, yeah. What happens in neonatal septicemia, as we all know, this is academic. Okay, very much yeah, pathology and this thing. Yeah, when what happens is, when pathogenic bacteria gain access into the bloodstream, whatever be it, whatever be the cause, like maybe it is a cut over the skin, or improper handling of the caregiver, without a proper hand wash and all, and this practices like all these cow dung around the umbilicus, and all these traditional practice these has a chance that the baby will come in contact with external organisms, and there will be a chance of getting bacterial infections. Okay, what happens once the bacteria has set into the body is, they may cause overwhelming infection without much localization. As we discussed, if septicemia means it is all over the body, it is a generalized term, there is no localization. That can happen. What is another possibility is, most of the times the newborns, only most of the times two organs will be affected. That is, one is lungs and one is the your CNS system. When the CNS is involved, it is the meningitis, and when the lung is involved, it is the pneumonia. Okay, so whenever you you should consider these things. When it is generalized, it is septicemia. When the lung is involved, you should think of pneumonia, and when the meninges are involved, it is meningitis. Okay, Yeah, classification. There are two subtypes based on the duration of onset. One is less than the number. Remember the number. Number is 72. Before 72 hours of life, it is early onset sepsis, and after 72 hours of life, it is late onset sepsis. Yeah, coming to the early onset sepsis, this is less than 3 days. In babies, we count for hours of life than days of life. See, it is 72 hours. Okay, so yeah, early onset sepsis, mainly it is due to bacterial acquired before or during delivery, because it is logical, right? Maybe the infection is from the mother itself, or during the delivery, yeah, like improper cord care or improper baby care. Okay, by organisms prevalent in genital tract or in the labor room or OT. Okay, this is common sense. Yeah, mostly caused by gram negative organisms, because once we're telling that it is genital tract organisms, obviously below the belt it is most of the organisms are gram negative organisms. So in newborns we should think of gram negative organisms, well, whereas in adults, or I mean in comparatively older children or adolescent age group, I'm pertaining to the pediatrics. Whenever there is a skin infection or any other infection, you always think of gram positive, positive. Like even pneumonia, your strep gives pneumonia, your staph gives pneumonia. Okay, it is of more positives. But in case of newborn, it is mostly you should think of gram negatives, because the source is either from the mother or from the labor room. The process of delivery may not be very hygienic and neat. So the baby can contact these organisms. Okay, yeah, majority manifest as respiratory distress. Sorry, it's RD means respiratory distress due to intrauterine pneumonia. As such, as we discussed, early onset sepsis can occur before birth or during birth. Okay, before birth, if the amniotic fluid itself is infected and the mother is having septicemia, that organisms can be filtered into the baby and can cause pneumonia. Okay, yeah, associated factors for early onset include, yeah, what can cause, like before the delivery or during the delivery, what can cause is your prolonged rupture of membranes more than 12 to 18 hours usually. Some books says 18, some books says 12 hours. Yeah, and foul smelling liquor or MSL, meconium stain liquor. See, once you see these amniotic sacs, they uh, keep the baby sterile and protected. Once the membranes are broken, there is a breach in the continuity. There is exposure of the baby to the external environment, and the organisms can get transmitted and can cause infections. Okay, yeah, multiple PV examinations by the gynecologist or the doctors, and maternal fever during or within 2 weeks of delivery. As we discussed, maternal septicemia itself, you see the maternal blood is having bacteria and that is getting filtered into the baby, and obviously the baby also will be having septicemia. And very low birth weight and preterm babies, yes, regarding this thing, what happens is preterms are more susceptible, because whatever immunoglobulins that are being there in the mother to protect the baby, they will be transmitted mostly in the late part of the gestation is like around your 32 weeks, 34 weeks of gestation. There will be transfer of immunoglobulins from the mother to the baby. So whenever there is a preterm which is delivered much earlier, like around 32 weeks or 30 weeks, the chance of immunoglobulin getting mean all the passive immunization like immunoglobulins from the mother may not go into the baby. Okay, so they will be more susceptible to the infections. Okay, that is why the catch of preterm babies is not immune enough to get to fight the environmental organisms. Okay, yeah. Difficult and prolonged labor, yeah, again your doctors, the gynecologist has the burden of this thing. Yeah, and but that's asphyxia and difficult resuscitation. Yeah, because once the baby is not crying, you don't mind the aesthetics of the thing, and everybody will be rushing in and out. It gets messy actually. So that can be one of the cause of getting infection for the baby. Okay, and pathological evidence of phenicitis and presence of polymorphs in gastric aspirates. Okay, these all are because of your baby being because of the mother's amniotic fluid and these getting infected. Okay, we can think of having a baby that may have sepsis. Okay. Yeah, coming to the important things, prolonged rupture of membranes, there is a risk of sepsis of 1% compared to the baseline incidence of 0.3. Okay, it increases the risk, okay, by 0.7%. Okay, and chorioamnionitis increases the risk by 3 times. And prematurity and low birth weight, as we discussed, 10 times the risk than a term or a normal birth weight infants, because as we discussed, the immunoglobulins are not getting into the baby, baby. And also the baby's immunity is not strong enough to fight the organisms as in comparison with a term baby. Okay, male gender boys have 6 times higher risk. This is all genetics. And in NICU, females, they do survive. That is an advantage. And male, yeah, it is at a higher risk actually. Okay, yeah, perinatal asphyxia. Asphyxia is associated with depressed immune function, and interventional procedures increase the risk of infection by 4%. As we discussed, once the baby is not crying, you don't mind all this thing. You need to rush and resuscitate the baby, so there may be uh, some here and there mistakes to secure these aseptic precautions. Okay, that can lead to the infection of the baby, and as such asphyxia can cause the immunity, improper immunity, like immunity function. So maybe the baby is getting more susceptible for the infection. Okay, this is all about the early onset. Early onset is 72 hours, less than 72 hours of life. So the cause may be at the time of birth or before the birth. Okay, and then coming to the late onset sepsis, which is more than which the baby develops sepsis after 72 hours. Okay, it is caused by organisms of the external environment or home or hospital. This is all to our burden, like how the doctor is treating and how the environment is taken care of, because the mother has taken care of the baby very well during the gestation, and now once the baby is out, how we are taking care of the baby. Okay, often transmitted through the hands of the caregivers. Okay, obviously the granny, all these they don't follow the proper hand wash technique, and they just handle the baby, and that is one of the reason. And the soiling of urine, stools, and those can cause sepsis. Okay, and here also the same thing. It is a gram-negative organism. So whenever there is newborn, always think of gram-negative more than your gram-positive organisms. But in any other condition, it is gram-positive more than gram-negative. This must be, yeah. Yeah, 1/3 of it is gram-positive, like cons, that is coil is positive Staph aureus, and negative Staph aureus also. And presentation is that of septicemia, pneumonia, meningitis, whatever it is. You just remember lung gets hit and your meninges gets hit, meningitis and pneumonia, along with septicemia, like all through the body. Okay, these three terms, your neonatal sepsis revolve around these three. Okay, sequelae in survivals of meningitis are usually severe. Like once the meningitis is there, they are more susceptible for hearing loss and other neurological manifestation. Okay, that is also thing to be taken, because the newborn's brain is developing and that getting infected, so your development of the nervous system also gets affected. Okay, the associated factors of late onset sepsis is, as we discussed, low birth weight, because they don't have proper immunity and they don't get proper immunoglobulins from the mother. Preterm babies, yes, the same thing, they don't get immunoglobulins from the mother. And delayed enteral feeding, because enteral feeding increases your capability to fight organisms, and this thing, that is the reason why they do your zero dose polio drops. And superficial infections like pyoderma and umbilical will deal with it. Infection, because more than 70, so something has occurred and the organism has to grow, develop, and cause a disease in the baby, so that the time lapse of more than 72 hours. Okay, yeah. And then there is mechanical ventilation. Yes, any invasive procedure, any you put a tube in the throat, you put a tube in the stomach, you put a simple IV cannula. If you're not doing IV cannulation properly, you're giving infection to the baby. So all these things do amount to your caregiver, be it a doctor or your the granny or somebody. Okay. Presence of IV catheters and percutaneous catheters, all these things, all the processes, you add the processor, that is adding your risk for infection. Okay, coming to the Yeah, early onset, late onset. Now coming to the case definitions, there are few terms that we need to actually know. Actually, the proven sepsis, probable sepsis, sepsis, and septic shock. All these things, they're different terms and they do mean something. Okay, actually, it is not all the same. Clinical picture of proven sepsis is sepsis. The baby looks having infection and isolation of pathogen from blood, your LP, I mean your cerebral spinal fluid, urine or other body fluids. See, once there is a clinical picture, and your lab is also giving septic picture. Your lab is your bloods, your CSF, urine or somebody, some ascitic fluid or your pleural fluid that is giving your infection. So that is proven sepsis. Yes, you are seeing the organism and the baby is sick, and you are seeing the organism. That is proven. Now, what is probable sepsis? Because clinically it is very difficult. Like if you're labeling somebody neonatal sepsis, the whole management changes actually. Then days, the number of days of antibiotics, the route of antibiotic, everything changes. So it is very tricky to get the diagnosis of sepsis from the newborn. Okay, yeah, what is probable sepsis is clinical picture suggestive of sepsis with investigations suggestive of sepsis, but blood culture is sterile. Okay, all the CRP or acute phase reactants counts are elevated, CRP is elevated, everything is appearing to be sepsis, but the blood culture doesn't organism. That is a situation where any organism for the growth. Okay, this is a tricky where maybe probably we are dealing with a case of sepsis. Okay, sepsis altered organ perfusion. You see, once the sepsis has set in and it is causing destruction of the body, that is when we say that it is sepsis syndrome. I mean, different things are being involved, so it is a syndrome. It is not a single thing. Different manifestations are there. That is why it is a syndrome. If untreated, leads to early septic shock and can be reversible with appropriate treatment. So this is why there should be a continuous monitoring in NICU units, because you see, once the baby gets sepsis, the baby doesn't give much time because it is a 2.5 kg, 3 kg physiology. So obviously, then the blood gets easily transported, the organism gets easily lodged in all the probable sites, and the organism can grow very fast compared to so the kids, they get very sick early, and once they get into shock, if you are not identifying shock, we may lose the child as such. Okay, so early identification and treatment is very much needed. Okay, this is to emphasize the need of it. Okay, if untreated, this state progresses to refractory shock and MODS. Once multi-organ dysfunction sets in, it is very difficult to get back the baby. Okay, all early identification and appropriate response makes the change. Okay, yeah. Now, yeah, all of the time we are telling that there is features of sepsis. Okay, proven sepsis or probable sepsis or septic syndrome, there are features. So what are those features that you see you're going to look in a newborn? The early diagnosis of neonatal sepsis is difficult, since most of the symptoms and signs are non-specific. You know, obviously the babies are not very much expressive, so you cannot see, look, and come to a conclusion. And the possibility of sepsis must be considered with any clinical deterioration unless the event is already explained by other causes. Okay, if there is any surgical causes and all, if there is clinical deterioration, you should something has to ring a bell. Okay, so what happens? What are the features that you need to look for, and what are the features that do give us a clue that we may be dealing with a case of sepsis? Okay, it is the lethargy. Okay, baby is not active, is not crying well. The baby is not comfortable, but the baby is dull. Okay, lethargy, refusal to suck during feeds, and poor cry. Even if the baby cries, there is less cry and gone, and not arousable. The baby is drowsy and it's not arousable. Abdominal distension, diarrhea, vomiting, hypothermia. Remember, in newborns, you use the term hypothermia. It is not fever always for infection. In pediatrics, in newborns, it is hypothermia is also sepsis. Okay, it is because of your SARS. Okay, severe I mean inflammatory response syndrome. Okay, because of that there is hypothermia and poor perfusion. Your CRF is increased, capillary refill time is increased, and scleroderma, it is the subcutaneous and generalized edema, and poor weight gain, shock and bleeding, and renal manifestation. And a few things are there to specify. As we discussed, these are all your septicemia things, like all the whole of the body is involved. And now there are few things where particularly suggestive of pneumonia, and few particularly suggests of your meningitis. That is, pneumonia is cyanosis, tachypnea, chest restriction, and grunt, apnea or gasping. And in case of meningitis, it is fever, seizures, and blank look, your altered sensorium, excessive cry, irritability, neck retraction may or may not be there in case of newborns, and bulging fontanelle because of the meninges inflammation. There can be bulging fontanelle. Okay. Yeah, the most common manifestation is your respiratory distress in early onset sepsis. As we discussed, it is your pneumonia, or it has to be your pneumonia or your CNS. Okay, in case of early onset sepsis, it is mostly your lung getting hit and causing respiratory distress. And in late onset sepsis, it is alteration in establishment of feeding behavior. Okay, for 3 days or 4 days, the baby is feeding well, okay, gaining weight, and like the baby is responding well, active, not lethargic, moving all four limbs, and all suddenly gets lethargic, drowsy, and not responding much, and not interacting to the mother very much. Okay, that is how your LOS presents. Like that is the complaint with which the mother brings the baby to you. Okay, then you should think of maybe you are dealing with a case of a late onset sepsis, because 72 hours have been lapsed. Okay, yeah. And hypothermia is more common manifestation of sepsis than fever. Yeah, as we discussed previously, it is hypothermia. Also, you need to keep, because it is the disruption of thermoregulation actually that causes for adults or adolescents. Yeah, we get fever because of infection, but in case of newborn, because of their primitive neurological status and the hypothalamus and other thermal regulatory centers, the hypothermia can be a manifestation of infection or sepsis. Okay, pyelonephritis is common in males and preterms. Enlarged palpable kidneys may be present. Pyelonephritis is your infection of your kidneys, right? Yeah, now a new organ has come, right? Kidneys are also can get hit, and in male and preterm they are common. Okay, now coming to scleroderma, we heard a name scleroderma. So what is scleroderma and what is it? Just to describe it, it is highly character of skin, and skin stretched over underlying structure and becomes unpinchable. Starts over face, neck, legs, and advances centripetally. Okay, in the periphery it starts and comes to the center usually. And the main thing is the skin gets taut and it gets unpinchable. Okay, that is how scleroderma presents actually. If skin over chest gets involved, breathing becomes very shallow and rapid, because the chest wall doesn't thick. I mean, the thickened chest wall doesn't allow respiratory movements, so the baby will find it very difficult to breathe in complete inspiration and exhale. Okay, that is how the chest movements gets impeded in case of scleroderma. Okay, remember that the skin gets thick because of fluid accumulation, the whole of the thing. Okay, it starts from the peripheries, your legs, head, neck, and then goes to the center. Okay, NEC, it is a necrotizing enterocolitis, presence at distended abdomen, passage of blood mucus per rectum. It is the enterocolitis, as the name suggests. It is the premature intestines. They don't do digestion well, and there can be infarcts and cause your NEC. That is necrotizing enterocolitis. Okay, how does it present? Is with abdominal distension, feed intolerance. There can be blood or mucus from rectum, bilious vomiting, and absent bowel movements, peritonitis. And yeah, obviously, when the blood is there in the stools, your stool will be positive for occult. Okay, any bone may be involved. Yeah, as we discussed, it is septicemia. Like the blood itself is contaminated or getting got infected. So all the organs, as we discussed, is pyelonephritis, kidney getting hit, The bone can get also giving rise to osteomyelitis. And septic arthritis is more common in hip, knee, wrist joints because of their large surface area and their tractional ability. Hip, knee, and wrist joints can get easily affected by septic arthritis. In case of newborn, I'm talking all about your newborn. Okay. Yeah, and how the joint appears is swollen, red, tender. Movement is limited, and once the baby moves the leg and starts crying, you move the leg and the baby cries. Okay, then you should think of maybe there is closely observed there may be swelling of the knee joint, redness of the knee joint, and warmth can be there. Okay, so that is how we should think of septic arthritis. Okay, if child goes into shock, shock means your cool periphery, prolonged capillary refill time, and peripheral pulses are not much appreciated. And obviously, if the peripheral pulses are not there, the circulation is not there, and there will be acrocyanosis, there will be bluish discoloration and ash appearance of the. These are all the signs of shock, as we discussed, because uh, sepsis can lead to shock very soon. Actually, within few hours, we may lose the child into shock. Okay, if you are not appropriately um, taken care of. Okay, if prolonged acidosis or hypothermia, DIC with DIC is your disseminated intravascular coagulation with manifestation also can occur if there is prolonged hypothermia or acidosis. Okay, acidosis is because of poor circulation. Okay, poor circulation, your lactic acid and other acids gets accumulated and gives acidic medium to the blood. Okay. Yeah, clinical suspicion of etiological agent. See, once you should think of the agent, because if you are not thinking of the agent, we may be fighting blindfoldedly, because we don't know the organism and we don't know with whom we are fighting. We just keep fighting. Okay, so it is Staphylococcus, usually after 72 hours of life, and present as pyoderma, conjunctivitis, umbilical sepsis, abscess, osteomyelitis, scarlet skin syndrome. All these things are the different manifestations of your staphylococcus. So that once you know that these are the manifestations, we'll think of staphylococcus. Okay. And listeria, if there is peripartal maternal fever, if the mother is having fever, and general examination of meconium stain like and the baby is not active and not moving all four limbs properly at the time of birth, and the AV anterior fontanelle getting depressed and respiratory distress syndrome sets in. There can be apnea and the skin changes. Okay, skin rash and hepatosplenomegaly, all these things they do give an idea of listeria. Okay, listeria is a mother infection, and then that gets getting transmitted into the baby. Okay, and pseudomonas and klebsiella, as we discussed, it is the gram-negative organisms that are causing the sepsis. There will be grayish black gangrenous patches of the skin. Okay, that is how we can identify that maybe we are dealing with a pseudomonas or klebsiella. Because this is important, because you can't wait on giving an antibiotic. You should just jump on giving an antibiotic, because once you are waiting for your lab reports, which are most probably getting delayed, the baby may not give you that much time. Okay, so we should think of the organism so that you can load the baby with the appropriate antibiotic, and meanwhile you can collect the report. Okay, that is why the importance of the clinical manifestation and the organism, so that once we know the organism, then we will do the antibiotics. Okay, yeah, these are some pictures so that you can appreciate. See here at the umbilicus, you can see the red base, and the stump is this is umbilical sepsis. Okay, umbilical sepsis. And there is peeling of skin like bubbles. Okay, these are previously it will be fluid filled. Okay, this is bulla like. Okay, all these things, all these things. Okay, this is SSSS. Okay, I think you know staphylococcal standard skin syndrome. Yeah, this is what we are discussing about. This septic arthritis, your knee joint. Okay, compared to the other knee joint, the knee joint is this much, and here the knee joint is very much enlarged. As if you can appreciate, it is a bit red, and if you touch it, it will be warm, and the baby will be not having good movements of this limb. And if you passively move the limb, the baby starts crying. Okay, all these things uh, put a light through maybe we are dealing with the case of septic arthritis. Okay, this is multiple melanotic. These are the multiple pustules. Okay, pustules over the buttocks and the back areas. Okay, they can cause infection. Yeah, this is what we are talking about. These Klebsiella and this can be there. It doesn't Klebsiella organisms. There'll be big patches. This mean that this is once this is the area, then you can start telling that it is Klebsiella infection. Okay, these also can. Here at the abdomen there is glistening skin getting taut. If you pinch it, you can appreciate it. There is no, this is sleeping. Okay, now coming to the the clinical manifestation, you have found, you have an idea about the organism, and yeah, and how do you do your labs diagnostic tests? There are specific and non-specific. Specific is your blood culture, because you will get the organism and you will know the antibiotic that is appropriate, and your CSF culture, you will get the organism and susceptible. Urine culture, same thing. And tracheal aspirate culture, if you are thinking of any pneumonia. Okay, and PCRs for your viral testing. Non-specific is your CBP, CRP, micro-ESR, and other acute phase reactions. Now we'll deal with this one by one. So blood culture is gold standard. Still, it is a gold standard. Okay, the blood culture should be incubated for at least 72 hours before considered negative. The late growing organisms are anaerobes and cons. Okay, staph negative, coagulase negative, staph. Okay, those are the late growing organisms. Okay, and backtech and these are the method which usually followed. I don't think backtech is there in our hospital. Yeah, though blood culture is gold standard, it is positive in only 60% of the cases, but it is the gold standard. Okay, once you see the organism, there is no second thing, like, yeah, something is growing in the blood. So yeah, we should think, and proper collection should be proper. Okay, it should not be contaminated. Yeah, CSF examination, your lumbar puncture, as we discussed, it is the meninges or the lungs. Okay, so yeah, you should also take care of the meninges things. Always do lumbar puncture in the suspected case of late onset sepsis. Okay, see, these are the normal values. So the total cells that can be present are around 8, but can be up to 30. If there is more than like 100, 200, 300, that means that we are dealing with an infection. Okay, and of which of the total cells, if the polymorphic nuclear cells are more than 60%, again that gives an idea of infection. And protein of value more than 90. Glucose usually comes down with bacterial infection. The normal value is 52, and CSF to blood glucose ratio which has to be maintained around 50 to 200. Okay, yeah, coming to the urine examination, as we discussed, you do blood culture, you do CSF culture, we'll do urine culture. Okay, urine examination, ideally we should take a suprapubic puncture and get the urine from the bladder, but as it is an invasive procedure and needs technique, we do the catheter thing. Okay, yeah, if there is more than 10 RBC, sorry, WBC in 10 power field, yeah, we can think of infection. Okay, now coming to the screening tests, the other non-specific things which can lead us to neonatal sepsis is, which indicate infection without identifying organism, because that is the non-specific. Specificity is, once you look at the organism, the organism is actually growing, then we can think of those things. Okay, now regarding the screen test, leukocytes like WBC or total count in the normal in a newborn is 8,000 to 20,000. That is all the normal range. Okay, and leukopenia is when there is less than 5,000. Okay, and absolute neutropenia is less than 1,000. These are the numericals we have to remember, because these are the this will be the criteria how we are going to look at the case. Okay, yeah, band cell count of more than 20% and band count is to total neutrophil count. If it is more than 0.2, again that suggests sepsis. Okay, what is a band form is, it is the primitive cell of your neutrophil. Okay, if there are more primitive cells, that means that there is an infection or ongoing process that is consuming the adult or fully formed neutrophils. So the premature has to come into the circulation from the bone marrow. So once if that ratio is tipping out to be more, like your bands are getting more and more, that means that the neutrophils which are mature are being used up or are being used because of an infection somewhere. So again, that will give you an idea of an infection. And the morphology of neutrophils can be different, like with the whole bodies, toxic granules, and coagulation. All these things do specify that there is a bacterial infection in the body. Okay, just coming down this thing, your total counts increase. Leukopenia can be there, can be as a manifestation of sepsis, and band cell to neutrophil count is increased more than 0.2, and abnormal neutrophils with toxic granules, dull bodies, and vacuolization, they can also be there as a marker for sepsis. Okay, this is mature neutrophil with 5 lobes, 1 2 3 4 5. Okay, this is mature. See, this is the band cell, which is a premature thing, and it will get into neutrophil. Okay, see, this band cell is because of this name. Okay, that is a band like nucleus, that's all. Okay, over time they will get more lobulated, more than 5 or something like this, as we see in your neutrophils. Okay, now coming a word about micro ESR. It is very the ESR tubes are Western green tubes, very long, which you must have seen in your physiology labs. But here micro ESR is just like a capillary tube, very inexpensive, small bedside test. A resident can do, your PG can do it. Okay, normal values increase with postnatal age. Day of life plus 3 mm. That is the normal this thing. Day of life plus 3 in case of postnatal age. Okay, more than 50 mm, 15 mm suggests of some infection. There is some inflammatory process that is going on. That is what the positive ESR, micro ESR says. Okay, this is less sensitive. Okay, and then C reactive protein. C reactive protein is synthesized by the liver following an inflammation. It is most reliable indicator of neonatal infection, and the level of more than 1. You see, this level of 1 and all these things, they do differ from your lab to lab. Okay, some say that 6 is the marker, and if it is more than 6, that is infection. Some say that 0.6 is significant. If it is more than 0.6, it is infection. Okay, so these things do change with the labs. Okay, you need to check the lab what they do as a standard. Okay, in suspected cases, repeat CRP after 12 hours. Okay, maybe there is usually what happens is the practitioners, we will be facing this. The baby will be dull, lethargic immediately after birth, and if we send the counts and all, that may turn up normal, but over a day or two, they can just topple here and there. Okay, likewise, that is why we have to go for sorry sorry in suspected cases, we need to repeat the CRP. Okay, whether it is because of the stress that is faced with the baby, or as such there is an infection that is sitting in the baby. Okay, serial decline in CRPs with the therapy indicates infection responding well to antibiotics, and elevation of CRP precedes relapse of infection. Okay, that is the same thing. CRP is your surrogate marker like thing, so that if it is there, you can think of infection. If it is not there, you can think that the infection is coming down. Okay, other acute phase reactants are few for academic purpose: prealbumin, fibronectin, transferrin, and procalcitonin. Okay, these are usually used, and procalcitonin is more advanced than all these things. Is produced by plasma of infected patients. Physiologically elevated during first 3 days of life. Normal value of 0.5. Indicator of late onset sepsis, more reliable than CRP. Okay, procalcitonin is produced because it has reacted with an organism. So your CRP, ESR, those things can be elevated with any small amount of stimulus. Okay, but CRP, the procalcitonin only gets elevated with an infected bacteria. Okay, that is the advantage that procalcitonin has. Yeah, these are the few acute phase reactants which increase during inflammation and which decrease during inflammation. Those things which increase with inflammation are CRP, C-reactive protein, procalcitonin, cytokinins IL-6 and IL-1R, and alpha-1 acid glycoprotein, haptoglobin, and alpha-1 antitrypsin. All these things they do raise. Okay, a few reactions decrease. That is fibrinogen, pre-albumin transferrin, and elastase alpha-1 proteinase inhibitors. All these things they do change. Okay. Coming to the septic screen, uh, what is the value of septic screen is you can rule out yes, this lethargic baby or this improperly feeding baby may be having sepsis. If you think that, you can get a septic screening done. It will rule out. Then if the report is positive, you can't label it as absolute sepsis. This is a tricky situation. If the report is positive, you can't freely label that it is a septic case. But if the blood parameters are everything normal, you can surely say that it is definitely not sepsis. Okay, it is something like your specificity and sensitivity. Okay, yeah, it consists of 5 elements. Just remember these things. This may be your theory question, or examiners may ask in the practicals. Okay, C-reactive protein, CRP, total count, your total WBC count, absolute neutrophil count. All these three are easy to remember, but the last two just remember because then relatively new. Immature to mature neutrophil ratio, ITR ratio, and microerythrocyte segmentation rate, that is your micro ESR. Okay, all these things they constitute. These are the normal values as we discussed. 0.2 micro ESR more than 15, CRP more than 1 hour dependent on the lab, and the count. See, low count as per Manrose chart for terms, and Mugino chart for VLW babies. Just remember the names because Manrose for term and Mugino chart for low birth weight babies. Okay, yeah. Two or more parameters of septic screen are positive, then we can say that. You see, we have discussed 5 elements. Okay, CRP, ESR, micro ESR, like that. Okay, if there are more than 2 positive, then 2 or more positive, we can push off and say that it is septic screen positive and start antibiotics. Okay, if all the parameters of the septic screen are negative in a neonate, low probability of sepsis, and antibiotic need not be started, and neonate must be monitored clinically. If, as we discussed, if it is negative, yeah, you can sit and think again of what is the other causes. Okay, the screen must be repeated after 12 hours, as we discussed, maybe because of the stress or something. The baby is maintaining the SATs and all these things. But once all this stress and comes down, that is over time, that is around 24 to 48 hours, then we can repeat this septic screen. Okay, 2 consecutive completely negative suggests no sepsis. Okay, because for blood culture, it is around 60 to 70% statistically can show the infection. Okay, evaluation and extension. LP for meningitis. Okay, okay. LP for meningitis, and urine examination, chest X-ray for pneumonia, and erect abdomen for your NEC or any abdominal infection, peritonitis, and stool for occult blood, as we discussed. Stool for occult blood can be there in infections, and bone scan for osteomyelitis. Okay. Biochemically, you do glucose, your all routine, your RFT, and the total bilirubin, electrolytes, and APG. And management, as we discussed, it is early recognition, and early recognition. Okay, then once you recognize, you push an antibiotic. What if the baby is not on antibiotics? You just push an antibiotic. And optimal supportive measures. Okay. Now coming to the specific antimicrobial therapy, like what are the exact medication that we give? A high index of suspicion of positive sepsis screen, so we should start antibiotics because we know that the report has come and it is growing something or this thing. So depending upon the prevalent bacterial flora and sensitivity pattern specific to each ICUs, see, our place may have staff. Maybe in Chennai it is Klebsiella. In Mumbai maybe it is Pseudomonas. So wherever we go, just see that what are the common organisms that are commonly infections causing common organisms. Okay, and constant reviewing and modifying the choice of antibiotics to be done as the flora and the susceptibility patterns keep changing. Periodic changes prevent emergence of antibiotic resistance. Okay, combination of antibiotics covering most of the pathogens to be started initially, as we know that once confirm that this is sepsis and all, so we should hit it hard, completing all the necessary things. Cephalosporins, vancomycin, meropenem are reserved for life-threatening, but usually we do ampicillin and aminoglycoside. Okay, I mean the primary, okay, elementary antibiotics we will do, and if it is not responding, then we'll shift to cephalosporins. Okay. In centers with high incidence of resistance to cephalosporins, piperacillin, tazobactam, and methicillin and vancomycin can be started. Newer antibiotics like meropenem can be given. Like meropenem is like you do meropenem for everything. Okay, infections due to ESBL, like extended spectrum beta lactamase organisms, should be treated with meropenem only, like because all other antibiotics will fail with it. Okay, if meningitis occurs, we should give a drug that crosses the BBB, blood-brain barrier, like cefotaxime, taxim, and ceftazidime plus amikacin. Okay, these are used for meningitis, and for Group B Streptococcus, ampicillin and and Klebsiella, cefotaxime and ampicillin, gentamicin, Listeria, ampicillin and gentamicin, Enterobacter, Serratia will give piperacillin, tazobactam, and vancomycin and gentamicin, Enterococcus organisms, ampicillin and vancomycin and gentamicin, and Pseudomonas, ceftazidime and cefepime. MRSA, this is methicillin resistant staph aureus, vancomycin has to be given, and coagulase negative staph aureus, vancomycin. So you do vancomycin for staph, you will be half correct. Okay, yeah. Duration of antibiotics, as we discussed, because once we diagnose that there is a sepsis or septicemia, we should give antibiotics, and the importance of growth is because how many days you are going to give. If culture and septic screen is negative, but clinically if he appears to be having sepsis, dull, lethargic, not poor feed, poor cry, and all these things, give for 7 days of antibiotics. Even everything is normal, because we never know. Maybe there is an organism growing somewhere. Okay, sepsis screen positive, but CSF and cultures are negative. Once septic screen is positive, it is 10 days of antibiotic, and if blood culture is positive, it is 14 days. Okay, when you think of meningitis, you should give for IV antibiotics for 21 days, and arthritis, osteomyelitis, and endocarditis, you may have to give for 1 month. Okay, 1 month and 1.5 2 months, because bony they because bone is the area where the vascularity is not much, so whatever antibiotics we're pushing in has to work on the bones, so it will take some time. Okay, so that time is around 1 month to 1.5 months. Okay, ventriculitis, it is your ventricle getting infected. Okay, and now coming to the supportive measures, what else you can do other than antibiotics is nurse ambient temperatures, IV fluids if internal fluids are not given, correct hypoglycemia present, vitamin K we have to give again twice a week until internal fluids re-established, because baby stomach has to adjust with the diet, other external atmospheres. Okay. Okay. Soda bicarb to correct metabolic acidosis. If there is an asphyxia, soda bicarb can be used. Volume expanders. If their BP is falling, dopamine can be given. FFP to correct poor perfusion and clotting DACs. Okay, and corticosteroids are given in very sick neonates with endotoxic shock. In septic shock, you can give steroid that to deregulate the overactive receptors. That is too much, but just remember that corticosteroids can be given for infections. And phototherapy and exercise translation for hyperbilirubinemia, oxygen and ventilatory support. Gentle physical stimulation if apnea is present, present, and drainage of abscess anywhere like diaphragmatic abscess or any other abscess anywhere. Okay, bleeding tendency, you can do blood or blood products. Okay, and treat seizures. As we discussed, meningitis, it will cause seizures. Okay, newer therapies or IV immunoglobulins can be tried, and colony stimulating factors with 10 mics per kg per day for 3 days, and can give for up to 5 days. Okay, and blood exchange transfusion may be performed in case of deteriorating sepsis with the scleroderma, provided the general condition of the baby allows the procedure. Okay, blood exchange transfusion is your last resort. Like if the doctor says that nothing can be guaranteed, okay, those conditions we can try. And oral administration of IgA and IgG in NEC are these are all in the trials, and newer modalities. Nobody knows when they will come. Granular set infusions. Okay. And how to prevent, as we discussed, proper hand wash, isolate the baby, take proper care. Bedside should be aseptic precautions have to be taken, all the bedside objects, and disposal of waste products in separate bins. Glucose, protein, and lipid solution should not be used, and IV inline catheters and bacterial filters and all these things, as we discussed, if there are foreign bodies sitting in the circulation, it will harbor infection. Okay, avoid overcrowding, as we all know now, and advocates proper staff and train them. Okay, and periodic surveillances and regular cleaning of the unit, and excessive use of breast milk, because breast milk contain immunoglobulin, so that will protect. And treat late onset sepsis with as a medical emergency, because as we discussed, the baby doesn't give time actually. Okay, that will conclude the class of. Okay, it is a bit fast and vague, but yeah. Okay, this is about neonatal sepsis. Just remember that organisms and appropriate antibiotics and different things. Okay, the rest is all just you can do. Okay, if there are no doubts, if there are any doubts, we'll take up the doubts for a few minutes, and then if there are no doubts, we'll conclude the class. Okay. Hello, is somebody there? Hello. Yeah. Manasa. Yeah. No doubts. Yeah, I understand this is a post-lunch session. It's very difficult. Actually, it is difficult for me as such also, but yeah, we have to get the class going, right? If there are no doubts, we'll conclude the class. Shall we?
Yes, sir.
Yeah, thank you, Manasa, and thank you all for your patience. Yeah, thank you for your patient hearing. Very
Thank
much.
you,
Thank
sir.
you. Thank you.